Hello everyone, welcome to Talking Health with Dr. Laz, your favorite health program on television. Yes, we are reaching you from Nigeria's capital city, Abuja, and every Tuesday we always talk about health, and today is a special day because the health issue we'll be talking about is about children. Recall that early this year, we had conversation with the Nigerian authorities, the Director of Family Health, and part of the focus of things she talked about is the reproductive, maternal, newborn, child, adolescent, elderly health, and nutrition multi-stakeholder strategic coordination platform. And what this means is in Nigeria is kind of a priority. I want to believe that in other countries in Africa, is also going to be a priority and for everyone around the world, because amid the COVID-19 pandemic, we want the health of our mothers and children to be optimal. So today I'll be having a pediatric surgeon for us to talk about the common pediatric surgery emergencies that present itself in the tropical countries around the world. Of course, it will focus more on the ones that we've seen here in West Africa and, of course, perhaps other parts of the world. Yes, I'll introduce my guest shortly. He's going to take a kind of classroom PowerPoint presentation, and we're going to be projecting some images. Some of those images you might find not so comfortable with because you're not used to seeing those kind of conditions. But please don't be scared. It's just for educational purposes, and we'll ensure that we explain it as much as possible in the language that you are going to understand. Yes, do follow us on our social media handles, all displayed on your screen, and don't forget to ask questions, make comments, even after the program until the next program. We're going to introduce my guests when we come back after the break. Do stay with us. I'll see you shortly. Welcome back to Talking Health with Dr. Laz, your favorite health program on television. So my guest is already here, Dr. Adulazeez Mustapha. You're welcome to the program.
Thank you for having me.
Dr. Mustapha is a pediatric surgeon at the University of Abuja Teaching Hospital, and he's going to be the one that is bring expert opinion as we talk about some pediatrics emergencies. Pediatrics talks about children. You're welcome once again. So let's get direct to the slides on the common pediatric emergencies. Let's get to the slide, please. Okay, yes, the slides are here, common pediatric surgical emergencies. So we have so many pediatric emergencies, but this one talks about the ones you may have to do operations for. Yes, the pediatric surgery conditions may present as
emergency cases and elective cases. So emergency cases are usually cases in which the child comes with an acute condition, and the child
what do you mean by acute condition?
Okay, acute condition in which the child is very sick.
Okay,
the child is very sick and on a short term, and that child needs some form of surgical intervention or some form of intervention at that point in time. So it's usually an emergency.
Right.
So what you do in such cases, you resuscitate. Resuscitation meaning we give IV fluids, you give the necessary treatment, and you prepare the child for the definitive procedure. Okay. Elective cases are cases that usually present, they present to us at the clinic. So you have more time to evaluate these patients, and subsequently you can then give the definitive treatment.
So those ones are the ones that are not like emergencies?
Yeah, they are not serious.
Maybe some kind of swelling that is not causing a lot of pains.
Yes, maybe.
But emergencies come to the emergency room.
Yeah, for example, a child that can't pass stool, that doesn't have an anal opening, which we'll subsequently see, is an emergency.
Let's move to the next slide.
So
get them.
Okay. So talking about the emergencies, there's usually a broad classification, but because of our time constraints, we just have to go to the specifics.
Yes.
You have a neonatal intestinal obstruction. Neonatal. Neonates as a child within the first 28 days of life. Okay. And the common causes of neonatal intestinal obstruction. Intestine, we all know what intestine is, and you have an obstruction, meaning this child can't pass stool. And the first cause, the most common, is anorectal malformation. Anorectal. Ano is anus, rectal is rectum. So malformation is just an anomaly. So you have a problem with the anus and the rectum. So usually these patients, they present in a very wide spectrum. But a common one is a child will be without an anal opening. So
okay, so the anus where a child passes or poo-poos from, there will not be an opening. So the child will not be able to poo.
Yes. So the child will not be able to, and you know, so you have accumulation of gas and feces, meconium in this case. So this child will come with abdominal distension, vomiting. And
what about the Hirschsprung's disease?
Hirschsprung disease is a form of functional intestinal obstruction. What you have is food.
I think there is a slide with a picture on that.
Yes,
so
we'll
talk about that when we get to
so
that
malrotation. Malrotation simply means there's an abnormal rotation.
Rotation
means
of what?
Rotation of the intestine.
Okay.
There's a during the fetal stage, when the child is developing, there's a way the intestine rotates. So I won't be going into details, but when you have an abnormal rotation, there's an obstruction. For example, if you have an incomplete rotation, it leads to a form of obstruction, and subsequently, these children will also have difficulty in passing stool, depending on the degree of obstruction.
Atresias?
Yes, atresia is like, atresia is just a failure of discontinuity. There's some form of, there's an atretic segment, and so you don't have the normal proportion of
okay, so if the intestine is it atresia of the intestine?
Yes, it's atresia of the intestine.
So if the intestine is supposed to be this long,
yes,
maybe it formed up to this.
Yes, actually what happens is you have different types of atresia, but the most common is what we have is you have the loop of bowel being formed. However, there is a gap. So with that gap, you have, that's what we call atresia. That's the atretic segment. So there's no continuity. The walls are not continuous. So subsequently, you have a buildup of gas and then feces in the proximal segment. And so the child will also vomit. Depending on the level of the atresia, the child could also have abdominal distension. And
yes, so, if you're watching, we are projecting this because you know some persons might want to see the pictures, or we don't have all the pictures to show you, but you can actually type this and search online and you'll be able to see. Some of the pictures look somewhat scary, so we don't want to show all of that on TV. You know, so, but this is just a broad spectrum of the common ones that you can see here in Nigeria. So meconium syndromes into susception. We need to quickly move to the other slide.
Yeah, meconium syndromes. The first stool a child passes is the meconium. So sometimes it gets inspissated, meaning it gets, it's like it solidifies and causes obstruction.
What's the color of that first stool?
It's usually greenish.
Right.
So and it should be semi-solid or just fluidy in a way. But when you have it being inspissated, dry, so it can cause obstruction. It could also be a meconium ileus, which is not that common in our own environment. Right. So they are all called meconium syndrome.
Okay, into susception.
Into susception is usually seen in the older children, usually infants that are usually being breastfed, and it occurs when they are being...
are people within 1 year.
Yeah, within 1 year of life, and it occurs when they are actually being weaned off the breast milk, and you're introducing complementary feeds. So most of them will come down with this into susception. What it actually means is that you have like telescoping of the proximal bowel into the distal one. So subsequently,
it causes... Is it that if this is a bowel lumen, you have another bowel, this one
going inside. So you have a luminal...
reduces the space through which feces will pass.
So that's what happens. So you have an obstruction, and it's actually an emergency. So the child will present...
let's move to the... Next, typhoid, perforation, acute appendicitis. Not many persons knows that typhoid, when it's not treated or when it's poorly treated, can actually perforate the intestine and cause an emergency. But it's not common in infants. Which age group of children is it?
It usually you see it in the school age and the older children. So that's where you see typhoid intestinal perforations. Usually occurs around the 14th day after the infection. You know, so when you're taking the history and seeing these patients, because acute appendicitis is also a strong differential. So you need to take a detailed history. You need to know when the fever started, what the pain is, when the pain started.
And by differential, we mean another health condition that may present in a similar manner.
Yes, so in a similar manner. So while taking the history and knowing when the fever started and also when the pain was actually noticed because in typhoid intestinal perforation, the fever comes before the pain. However, in acute appendicitis, the pain comes before the fever.
That's very good to know. So can we move to the next slides? These are elective cases. We will not going to be explaining all of them. Some we've already mentioned, but it's just projected for people to see because we have a lot of pictures we need to discuss, and time is already being well spent. Yeah, let's move to the next. Okay, childhood tumors. I could see an abdominal distension. What are the potential pathologies that can lead to this? Okay,
the potential for this age group, usually we have what we call Wilms tumor. A Wilms tumor is a tumor of the kidney.
Nephroblastoma, right?
Yes, nephroblastoma.
Okay, kidney.
Yes, so you have a tumor in the kidney, and usually the interesting thing about it is it's usually not that symptomatic, and the mother might just notice a swelling while bathing the child. So, however, late presentation will present this way when you have, you know, it grows subsequently, and you can have
neuroblastoma also?
Yes, neuroblastoma is also a strong differential. Neuroblastoma is actually the most common solid abdominal tumor. However,
for children or all age groups?
Yes, you have, there's a spectrum also. You know, the younger ones tend to come down with neuroblastoma, while older ones, like when you see a child like 1 to 2 years of age with an abdominal mass, you should think more of a neuroblastoma. However, 3 to 5 years, you think more of a Wilms tumor.
I'm sorry, I wish I can break down this neuroblastoma, but I don't know the simpler language to use. Okay, let's move to the next. But hepatoblastoma can also
yes, hepatoblastoma
can also,
liver, yes,
right?
That's the liver. Yeah, liver, hepatic.
What about bucket lymphoma?
Bucket lymphoma, yes. You can have buckets in the intestine, in the kidney. And so we call that renal bucket, yes.
Okay, essentially when the previous picture we had, a child's abdomen is distended, there are so many things that may actually be causing it.
Yes,
so you should see a doctor and know which one is it. So
this is Hirschsprung's disease. This is also a late presentation of Hirschsprung's. You can see
is that the veins?
Yeah, those are the abdominal veins that are dilated.
Do you need to vascular obstruction to present with this kind of distended veins?
No, the problem with this patient is actually the Hirschsprung's. So you just have the veins are just being, it's the tension that is causing all this, you get. Okay. So your main attention shouldn't be on that. It should be on what is causing the distension. Because this child is accumulating gas and feces. So cannot pass stool, and you need to relieve that intestinal obstruction. Sometimes you might have to give a colostomy, which we'll subsequently see.
Okay, we'll take a short break shortly, but before that, this Hirschsprung is the nerve supplying the intestine.
Yes.
There is absence of it in some parts, so because of that, that segment of the intestine cannot move.
Cannot move. The peristalsis is usually absent. So when you have that peristalsis being absent, subsequently, that's why it's a functional intestinal obstruction. It's not as if you have anything mechanical obstructing in this case.
By peristalsis, it talks about the movement of the intestine. Whenever we eat food, our intestine kind of contracts and relaxes, and that's what pushes the food we eat. The body takes the one it wants. The feces that is formed is pushed out until you feel the urge to pass it out. So when the nerves supplying a part of the intestine is not there due to certain malformations, it may cause obstructions that can be this severe. Okay, so let's take another break, and when we return, I'm going to continue this very interesting conversation with Dr. Adulazeez Mustapha. Do stay with us, we'll be right back. Welcome back to Talking Health with Dr. Laz, your favorite health program on television. Yes, back to it. Let's move to the next slide, Dr. Mustapha. So this is colostomy.
Yes.
What does it mean?
Okay, colostomy simply means you're bringing out the colon, which is a
large intestine.
A large intestine, yes. You're bringing it out through the anterior abdominal wall. We usually do this for children that don't have anal opening.
Okay.
So, as a form of an emergency intervention, you need to bring out the bowel so that the child can subsequently pass stool. And the child will do well with this.
Pending when
we now
major corrective
evaluate
surgery is
and
done.
we do the definitive surgery, usually after about 4 to 6 months.
Okay. So let's move to the next
Okay. This is
sacrococcygeal teratoma.
Yes,
is there any simple language or
well, yes.
any African or Nigerian language they used to describe this?
Yes, it's actually, the sacrum is a part of, if you look at the bony skeleton, the sacrum, then the coccyx is the lowest point.
The tail part.
Tail part. So it's just that sacrococcygeal.
Is there a Nigerian or African language, that a local language you can use?
Well, I think just that anatomical. Then the teratoma. Teratoma are just tumors that usually are like their germ cell tumors.
This can look very scary for parents.
They present usually newborn. You can see this is a newborn. However, the interesting thing is you can pick it with a routine antenatal scans.
Okay, so during antenatal care, the obstetric scan can pick this.
They can actually pick it, inform the pediatric surgeon, and the pediatric surgeon would be primed. You will be prepared
before delivery.
Before it. And also, fetal intervention can be done in some cases. But, in our own environment, we don't have all that facilities. But in developed countries, you can actually intervene and even resect this tumor. While the child is still in the womb. You bring the child out, you resect the tumor, and you take the child back into the womb.
What does it take to have that kind of skill here?
Well, it requires a lot because the expertise. Expertise, and also
a separate conversation on its own.
Yeah, then a form of anesthesia in which you have to actually, the child will still be connected to the mother via the placenta. So you need to, and that means you're dealing with two people now.
Right. So after birth, what does the pediatric surgeon do? How early is the surgery performed for this procedure?
Okay, what we do is usually is a clinical diagnosis. However, we also have differentials. So what we do is we try to confirm our diagnosis, and once we do that, we have certain investigations we carry out. So once we do that, most especially the alpha-fetoprotein, once it's usually raised in them.
Yes, how soon?
So, once we've done that and the child is stable, we operate within 48, 72 hours.
Okay, of birth?
Yes, of birth. We don't have to keep the child.
So let's move to the next. Yes, disorder of sexual differentiation. What does that mean?
Yes, disorder of sexual differentiation is, these are children in which you can't actually pick out the sex.
So do we say it's hermaphrodites?
Well, phenotypically in the sense that when
phenotypically means the one we can see.
Yes, when you look at the child, all parents, they want to know, is this a male child or a female child? You get. But when you look at these children, you can't actually pick it out. You can't pick the sex. So that's why it's being called the disorder of sexual differentiation. For example, this child is actually a female. When you do the karyotype, the karyotype shows 46XX. So what's happening here is like the clitoris is actually being enlarged. We call it clitoromegaly.
Yes.
So you have a lot of male hormones, so the genitalia is being virilized, and you have such. So and you can see that it's looking like a male genitalia, but you can see you can't see the testes.
Yes.
So this child will actually have ovaries, which will still be intra-abdominal.
Okay, so what will you do for this child?
What we do is, the first thing is you have to confirm that this child is actually a female. So after we have to do the genitoplasty. So feminizing genitoplasty is being done, and the child will do.
So by feminizing genitoplasty means they will do a surgery that will remove what makes the child look like a man,
and make the child
look more like
a female.
A female. Yes, just for our knowledge, when a baby is forming, they are essentially the same, but at a certain level during the formation of a baby, the estrogen helps in the development of the female organs. While the testosterone helps in that of male. So when you have higher level of testosterone as you're supposed to, you can have a female, presenting like this. Let's move to the next, please. Anorectal malformations, we mentioned it in the beginning. Yes,
so this is a male child with, that's a subepithelial tract being filled with meconium, and there's no anal opening if you look down.
Okay, so there's no opening for passing of poo-poo.
And this child might actually be passing stool passing the stool through the external meatus, through the penis, because there could be a fistula.
Okay, so by fistula it means there's a connection between the outside
between the rectum now and the urinary tract.
Interesting.
So because, yes, so usually the malformation,
so could
you
that
have
be rectourethral fistula?
yes, so that's the most common in males. You have an anorectal malformation, that's the absence of the anus, and now you have the communication with the urinary tract.
A male child will be passing urine and passing feces through the same place.
To the same place, and also there's no anal opening. So this child will need a colostomy, because if you don't do that, the thing is you have contamination of the urinary tract with the feces,
which can lead to urinary tract infections.
However, in some cases, once it's a low anomaly, there's a term we call low anomaly, the child can actually get the definitive surgery done immediately. But once there's a fistula, you must do
colostomy first to bypass the
feces. Then you start evaluating.
All right, let's move to the next. Yes, umbilical hernia. This is pretty common.
Yes, this is umbilical hernia, and I think it's usually not cosmetically acceptable. So that's why a lot of parents will come around.
So, but over time it closes, right?
Well,
for many of them.
Yes, for some. But the thing is, you have what you look at before it closes. Okay. Because if a child that is of 3 years of age and has a defect of more than 1.5 cm is unlikely to close.
Okay.
And so also, if you look at this child, this is a very wide defect. Yeah. So the closure depends on the age of the child and also the size of the defect. And also, if this child comes down with symptoms, because they could actually obstruct what is coming out of that defect, could get strangulated, could get obstructed, and this child will need an emergency intervention. Yes. You have to close that defect and return the...
if this remains up to, you say, 3 years or 3.5 years?
So 3 years with a defect of more than 1.5 cm, we need repair.
Okay.
But with experience, once you see a child even at 2 years of age and you look at the size of the defect, you can just do the maths and
know. So for parents who have children with these big umbilicals, and they are up to 3 years and they are still very big, please go to a hospital and see a pediatric surgeon, because if you leave it, the intestine may actually come out there and get strangulated and lead to an emergency. Okay, so let's move to the next. This is a gastroschisis.
Yes, it's an abdominal wall defect, and the children, they are being delivered this way. You have the bowel eviscerated. Eviscerated in the sense that...
abdominal wall defect means parts of the abdomen didn't form, and the place is just
open. And the content of the peritoneal cavity, that's the bowel, herniates and comes out of that defect.
This looking gangrenous.
Yes, that's the challenge, because the defect is usually a very small one, just about 1 cm. So it can actually constrict the vessels, the mesenteric vessels that supply the bowel. So subsequently, you have gangrene.
So in this situation, what do you do?
So in this case, what we usually do is the first thing you do, you look for a way to widen that defect, ensure there's no constriction of that.
Well, you've seen that there is perhaps gangrenous bowel and all
yes, when there's gangrene, you have to examine carefully, because if you are removing this whole bowel, the child might have a short gut syndrome or a short. Yes. So what you do is, we give it sometimes. You can use a warm saline. You soak it in gauze. You soak the the gauze in warm saline, and when you apply it, sometimes the bowel might recover. But that constricting ring, you must make sure you widen the defect.
It so that it will not continue to cause.
Yes. So then you take the patient to the theater. Sometimes the abdominal domain might actually accept this bowel back, but sometimes it might not. You might just do a silo. What we call a silo is you modify. You get like, sometimes we use a urine bag. If you don't have the spring-loaded silo, put the bowel there, and you start reducing gradually. It reduces by gravity. And
our time is very fast spent. We just need to round up. But these things will be interesting to people in medical sciences, not just for the entire population. I recall during our med school, these are picture tests, They project it during exams and ask many questions. I will have to be answering it. So omphalocele.
Yes, omphalocele
is also... Any local language name for this?
Well, yeah, I think the picture is doing enough justice. Omphalocele is just, you have something coming out, also an abdominal wall defect, but this time around coming out from where the umbilicus is meant to be, but it's covered.
Okay.
Unlike the other one that is
That
not
is
covered.
just open
So what you
and-
have is you have a layered membrane that covers it. However, it could also rupture. So this
Okay.
is why we want patients that have this, once they are being detected prenatally, they should come and go to hospital with
prenatally
specialists.
means when they are still going for antenatal. This
Antenatal
is one
screening.
of the reasons we say women should go for antenatal care.
Yeah.
There are many things that just that ultrasound that is interpreted by a gynecologist or a medical doctor with the skills, can show. And if you have things like this, you begin to prepare ahead of time even before the child is delivered. I think we are getting to almost to the end. Next slide.
Okay, this
Inguinal hernia.
is inguinal hernia. This
Is
is
this just
very
inguinal, inguinoscrotal? The
well. We call it
scrotum is,
inguinal in the sense that it's a scrotal swelling, but we just call it inguinal hernia in pediatric surgery.
Okay.
So what it means is you have there's what we call a patent processus vaginalis. So there's a communication between the scrotum and also the peritoneal
Abdomen.
cavity. So you can have fluid. When you have fluid, it's a hydrocele. When you have bowel contents coming in, that's the intestinal loops, you call it an inguinal hernia. This is actually a bilateral inguinal hernia.
Yes, so the bowel loops is the intestine getting into where the scrotum is supposed to be.
So all you need to do is, this you need to fix it.
Surgery.
Yes, surgery.
All
because
right,
the bowel can also
please.
get strangulated and obstructed. So
do we have next, please?
I think that's the...
Okay, so that's essentially the ones we can show. Dr. Mustapha, I believe people would have learned a lot. So what's your last word in 10-15 seconds to our viewers? If they find any of these, what do they need to do?
Okay, so my last words are just that most of these cases, you can pick them prenatally from your prenatal ultrasound scan, and adequate referral can be made, and specialists, that's the pediatric surgeons, can be consulted even before these children are being delivered.
Okay,
and
so
it helps
the
a lot.
solution is pregnant women, please go for antenatal care.
Okay.
Go on for antenatal care and have ultrasound done. And if there is any abnormality, please see a gynecologist if you were not seen before by a gynecologist, and they can bring in pediatricians or pediatric surgeons. I really thank you, Dr. Adulazeez Mustapha, pediatric surgeon, and works at the University of Abuja Teaching Hospital. Thanks for being on this program and enlightening our viewers.
Thank you very much.
And to you, thank you so much for being with us today. We'll do this more often, and we keep encouraging you to ask questions and keep the conversation going on our social media handles. My name is Dr. Laz Eze. I'll see you same station, same time next week. Bye for now.